Okay, thanks.
So the next presenter is Dr. Pinky Patel. Are you there? Yeah. After this, Dr. Monica Barik, please be ready. Dr. Monica Barik, the next one.
Good morning, everyone. Myself, Dr. Pinky Patel. Good morning, everyone. Myself, Dr. Pinky Patel. My topic is to study clinical presentation and visual outcome of tubercular optic neuropathy. Introduction. Tuberculosis is an infection caused by the Mycobacterium tuberculosis and is most commonly occurred by the inhalational route by which infectious agent enter in the lungs and primary infection is stabilized. The hematogenous or lymphatic spread can result in involvement of the other side. Ocular involvement is reported 6.8% of patients with pulmonary tuberculosis. Tuberculous optic neuropathy may follow infection with Mycobacterium tuberculosis or administration of the bacillus columate carrying vaccination or as a result of hypersensitivity reaction. The report of clinical manifestation of tuberculosis disease increase in the literature. Disease may reflect direct infection or an associated hypersensitivity reaction. The manifestation of tubercular optic neuropathy comprises of optic neuritis, retrobulbar neuritis, papillitis, neuroretinitis, papilloedema. My aim is to describe clinical presentation and ocular outcome of tubercular optic neuropathy in tertiary eye care center. Material method, retrospective hospital-based observational study, duration 1 year, in tertiary eye care center, Jharkhand. 9 cases associated with tubercular optic neuropathy who present Department of Ophthalmology. Informed consent was obtained from each patient prior to enrollment in the study. Inclusion criteria, all patients with tubercular optic neuropathy during study of 1 year were included. Examination included external examination, best corrective visual acuity, near vision chart, color vision, extraocular involvement, pupillary reaction, anterior segment examination by slit lamp, IOP, dilated fundus examination by direct and indirect ophthalmoscopy. Renal liver function test, serum electrolyte, blood sugar, urine routine examination, BDRL, torch profile, HIV, chest X-ray were done. Montex tests were done to look for tubercular etiology, which turned out to be strongly positive. Suspecting tubercular meningitis, lumbar puncture done. CSF in which lymphocytosis, low glucose content and high protein and ZN staining positive for acid fast bacilli. OCT examination for thickening of retinal nerve fiber, Humphrey visual field done for visual field defect and MRI orbit and brain was if required. TB was confirmed by identification of acid fast bacilli in 1 case and presumed in 8 cases on the basis of positive PPD or gamma interference release test. For drug ATT was given 55.56% and ATT with adjuvant systemic and topical steroid was given 44.4% of our patient. But all patients who agree to treatment and continue in follow-up monitor closely for deterioration in color vision, visual acuity. Visual field following initial improvement may indicate drug toxicity under pulmonology consultant. In addition, pyridoxine is routinely combined with isoniazid to protect against peripheral neuropathy. Result out of 9 cases, 6 male, 3 female, 7 patients unilateral, 2 patients are bilateral. Presenting symptom, decreased vision, pain, visual field loss and other. Sign uveitis was additional ocular morbidity in 88.7% of the eye. Final visual outcomes 612 to 624 at present 2 patients on ATT, 3 patients on ATT plus corticosteroid, 3 patients. Visual acuity 636 to 660 at present 3 patients on ATT, 2 patients and on ATT plus corticosteroid, 1 patient. Visual acuity less than 660, 4 patients. Conclusion, in this study out of 9 cases with tubercular optic neuropathy, the disease was typically unilateral and the majority of patients presented with painless decreased vision and papillitis. Ocular manifestation should be watched for in all patients of both pulmonary and extrapulmonary tuberculosis. No significant difference in outcome was observed in patients treated concomitantly with ATT drug and steroid versus anti-tuberculosis drug alone. Pre-ophthalmic workup and regular ophthalmology follow-up when ATT started. Never hesitate to do neuroimaging to confirm the diagnosis and plan for management. Discussion. Optic neuropathy in tuberculosis occur due to tubercular perineuritis, papilledema, consecutive optic atrophy due to rage, intracranial tension, intraotitis of optic nerve, toxic neuritis due to drug. Visual outcome were good and were not impacted by the use of corticosteroid therapy. Intraocular tuberculosis can be primary when the entry of bacillus is at eye level. Secondary in case it appears as a result of hematogenous dissemination from distance and nearby focal point. Ocular involvement occurs approximately 1 to 2% of tubercular patients. It was usually distributed to other infection. The patient must be counseled about possible impact on vision and symptoms. They should watch for presence of which is imperative to see the ophthalmologist. A clinical diagnosis of ocular tuberculosis is difficult due to a varied presentation and other indistinguishable for other case of uveitis. These are my references. Thank you, sir.
Okay, thank you, Dr. Pinky. I had one doubt. In which cases did you give like this systemic and topical steroids, and why? You were
Ma'am?
telling that you gave adjuvant systemic and topical steroids in addition to ATT. So in which cases you did give this?
Ma'am, in tubercular patient,
In tubercular patients you are giving ATT. Is there any need for additional adjuvant steroids, systemic as well topical? It's not needed in all patients. Why you have given in certain patients? You are telling that you have given in very few patients adjuvant steroids, systemic as well as topical. So why did you give? And with which patients?
See, I was going to ask the same question in the other way as why it was not given in all patients. See, because you are calling this tubercular perineuritis. Okay. There is one thing about it. You are saying 85% of the patients came as painless loss of vision.
ji sir.
And at one point in the presentation, you are saying majority of these patients were uveitis. So
Yes.
then that didn't add up somehow.
Yeah, actually this is not matching. Like 88.7% you are telling present with uveitis. So you're giving the steroids for the uveitis.
How did you differentiate between whether it is the optic nerve involvement is because of drugs or because of the disease per se? So you have mentioned that a few drugs can cause neurotoxicity. So
Yes, sir.
whether it is caused because of the tuberculosis disease itself or is because of the drug toxicity, is there any way of finding the difference?
Sir, color vision.
It's a presumptive diagnosis. You are presuming that tubercular is the etiology, but it's not
Ji sir.
necessarily always correct. See, you have to distinguish between presumptive and causative phenomena. Presumptive is your presumption. It's not necessarily accurate. Whereas causative is where it is the cause. If it is causative, the treatment of the cause cures the condition. If it is presumptive, nothing happens. Okay. Never mind.
And also when you are telling that you had done the LP, but did any patient present with tubercular meningitis, or in all patients you did the LP?
Sorry.